This conference will now be recorded.
Good afternoon, everyone, and morning for those on the West Coast. My name is John Dzivak. I am the chair for the ACRM Pandemic Task Force, also CIO VP for PT-PAL. We are hosting a session today in a series of sessions regarding telemedicine in ancillary services. We've gotten a lot of questions, and ACRM has a lot of members that have posted questions around how to do telemedicine, telehealth, e-visits, remote patient monitoring during this pandemic, and how to get paid. So we're going to be having a series of sessions on Tuesday, Thursday, and Friday going forward. Today we have Brian Scarpelli, who's the Senior Global Policy Counsel for the ACT App Association's Connected Health Initiative. Brian focuses on improving the uptake of connected health technology through updates to reimbursement, security, and privacy, demonstrating the efficacy of technology to improve care while reducing costs. His role has led CHI's efforts to accomplish groundbreaking changes in the physician fee schedule, quality payment program, and other bellwether federal beneficiary programs. Can I get everybody to mute their calls, please? Thank you.
Why aren't you working?
Establishing new CPT codes that appropriately categorize the use of connected health technologies in care delivery, among other significant breakthroughs. So Brian's group works very closely with lawmakers on the Hill actively every day, trying to get some changes through so that all health providers can enjoy the benefits of telemedicine and remote patient monitoring. Brian, are you on?
Hello, I'm here.
Great, great. All right, so I'm going to share my screen. Terry?
Yes, John, are you logged in under PayPal, PT-PAL?
Yeah. All right. And share. All right. All right, Brian, are you there?
I'm here.
Okay, so I think we're all set. I've got the slide deck up if you can see it. Welcome to the call. I know that you're extremely busy with all the changes that are going on around reimbursement. So I'm glad that you had time to talk with us today.
Absolutely. It's great to be here to meet you all virtually. I am grateful to you all for your time. Really, it's really cool. Amazing to see 132 people on this call right now. And you know, the work that you all are doing couldn't be more important, obviously, right? So, you know, if you look at my deck, you'll see that there's a great many slides that kind of probably would have been content that I would have presented on to you before the COVID-19 pandemic occurred. I didn't, you know, I didn't cut all of that. I wasn't going to spend a ton of time on all of it though, and I just kind of left it in as a resource. And there's some links in there and things like that. I just hope that it's helpful and it can give us maybe kind of a good baseline, but I would just kind of breeze through that. A little bit about myself and my organization. Who am I? You know, why do I care? Is a fair question. The Connected Health Initiative. It's a not-for-profit policy advocacy group that is basically attempting, in a sentence, to advance the responsible deployment and use of digital health tools across the care continuum in any way possible, whether small and incremental or sweeping and condition agnostic or anything in between. You know, rather, I won't go on too much about this other than to say, to give you an idea about where our organization is coming from, we have a steering committee that is, I think, a pretty interesting mix. It ranges from the physician community itself, the American Medical Association, to some academic medical centers in both urban and rural areas who have really interesting and unique challenges and are doing really innovative stuff with digital healthcare tools, to a wide range of private sector interests, from small startups to a few larger companies, some with pharmaceutical, working on pharmaceutical medication adherence stuff, for example, the payer community through United Health Group, and then also just what people might consider just tech companies, Apple and Microsoft, for example. So I rattle all those off to say anything we're working on has this kind of thread of agreement across all those different communities. The widget we're basically making is federal level advocacy on digital healthcare topics.
Mm-hmm. And I think that I just want to point out to our listeners at this point is, so my company has been a member of this for quite some time. CHI had a call this week on Monday. Gosh, that seems like a long time ago already. And one of the things that people worry about is that they're making their decisions about whether to join in telemedicine based on up-to-date information. I wanted to tell everybody here, Brian's group's literally getting text messages from the Ways and Means Committee as they're deliberating on the Hill. So like the information that we're posting today is absolutely, this is as it's being crafted, we're posting it to you. So, this is, as it's happening, the sausage is being made and we're trying to prepare to get in front of you. So the information we're presenting today is absolutely as up to date as it gets. So just to kind of, that was really where I wanted to go with, your background, making sure people can trust the information, because we're hoping that the information that we're providing today is going to let these decision makers go back to the group with their rev cycle partners and, get permission essentially in order to participate. And so I think I want to make sure that people understand where you're coming from and that this information, like the paint's still, or the ink's still wet as far as this draft goes. So
couldn't put it any better. It's really is, and this is really unprecedented too because for this organization's, the Connected Health Initiative is something like 6-7 years old at this point total. Things have never moved this fast, but there's probably good reason for that. Yeah. At the same time, though, there's potential for conflation. There's potential for unintended damage, and at the same time, there's potential for incredible advancements that we've been unable to make, and I can talk about some of those, I guess. There, some of these slides here I can go through real quick, but this is something that I always display whenever I present. Basically, there's like these 3 questions that kind of underlie, all the different policy areas and asks and things that we are working on. Does it work? Who gets paid for it? Well, that is a cynical question. It often does come down to that. And then lastly, does it work? And that kind of speaks to the liability question. These reflect some working groups we have with our group, and I won't go on about those, but okay. Yeah, go to the next slide.
So I want to remind everybody, this session is more multidisciplinary. We do have sessions that are coming up that are focused on individual disciplines. So we are going to have time at the end that we're going to save for chats. So if you have questions that come up around your particular discipline, or even just generally, whether, or maybe, it's peds related or home health or whatever, post those in the chat, and we'll make every effort to get through those at the end of the call. So let's get right into it, Brian. Everybody wants to know who can play, who can participate, who can provide these services, who can provide them and get paid, and what are the differences between some of them. So you have a lot of information in here. Let's, everybody knows this is a big.
Yep, we're preaching to the choir with these slides, probably.
This is front and center on everybody's mind that's on this call. Yeah. Okay, so I thought we could maybe start with here. You've got some terms and definitions, and a lot of people who are on the call, I'm sure, are very new to telemedicine, telehealth, visits, and remote patient monitoring. So I kind of wanted to, sort of set this, like what we're talking about here, and what maybe some of the differences are between some of those points.
Yeah, absolutely. Yeah. So the that first bullet is probably a key one, and telehealth versus store and forward. What that's really talking about is that the Social Security Act, which which provides the authority essentially to the ultimate authority really to CMS for its payment systems. That statute goes back to the early and mid 90s, and in it creates it has a statutory mandate for payment for Medicare telehealth services, and then it goes on to define those telehealth services as, in effect, only a live voice or video call, nothing further. So really only one modality, and it basically provides a bunch of limitations to where and when that live voice and video can be used. Some of which I would argue have almost make no sense in a modern world, and I'm sure they made great sense to Congress when they adopted them in the 90s. But you know, for example, excluding the patient's home from being an originating site of care. I can't really find anybody who thinks that's a great idea any longer.
And I want to get to that because those are some of the things that I know that are changing.
Yes.
So should we go to? I think this is really where we're starting to get to. You know, this is sort of the secret, like this is where everybody's really focused right now is. You know, 99991, the remote patient monitoring codes, chronic care. Can you give us kind of a rundown on what some of these are, who can use them, under what conditions, you know, what gets paid? You know, I know some of the G codes you can use them, but there's no revenue that's behind them. So can we do kind of a rundown here to help interpret some of this for our listeners?
Absolutely. Yeah. So you know, that was kind of the last slide or a few slides were kind of historical background, and you know, and something that people have been complaining about for some time. To make a very long story short, in the last few years, and you can see calendar year 2018, 2019 physician fee schedule is when we really started to get a breakthrough, initially starting with the unbundling of the code for interpreting and collecting physiologic data across a month. You know, and that's the 99091 code, and then they built on that. So at this point in time, we have a CMS that agrees about the value of using different modalities of digital healthcare. They agree that the statutory restrictions they can avoid for Medicare telehealth services should not be applied to further modalities outside of live voice and video. And so they've adopted further, they've activated and paid for certain CPT codes that were developed through the AMA's proprietary process, and then they've also created some of their own HIPAA codes for different use cases. And you kind of see them all listed here. I think who can basically use them? Well, the threshold for, you know, basically, you know, it's a question that we've gotten a lot actually. Because there's not total clarity from the agency on all this stuff, but they're all in Part B. So this is all Part B of Medicare, if that helps. So if you're not billing Part B, then you probably would not be able to use the bill, send in a claim to Medicare and have it be filled. But you know, I mean, one thing we've been advised. To be honest with you, I hear conflicting information, and part of this actually. You know what, before I say the conflicting information, I should say, when CMS adopted regulations for these codes you see listed, and then some further codes in later slides, including one slide has a chart in it that shows the payment for what it's worth, just for people to consult. CMS acknowledged that there's a wide range of questions around the use of these new technologies in Medicare. And they said, wow, we really appreciate hearing all these questions. We will develop guidance for stakeholders that will clearly explain who can build the codes and when they can't, and answer other questions about what types of technologies and scenarios are envisioned by the agency and things like that. And we're still waiting for that guidance, so we don't have it from, you know, from the horse's mouth, CMS, unfortunately. So the experience.
You're talking about 99991 specifically right now.
I'm talking about really 99453, 7, and then a new code 99458.
Brian, I'm getting some feedback on the line.
For me? Oh, I'm sorry.
Feedback on the line.
I'm
Can-
looking to try
yeah,
to control that.
Their phones.
So if Van Luthke could mute your phone, that seems to be where some of the feedback is originating from. Thank you.
Great, thanks. Sorry, go ahead, Brian.
No, not at all. Yeah, if you advance maybe a slide or two, folks might see what I'm talking. See the specific codes for the guidance I'm talking about. Yes. Okay. So this is more of a resource. If you keep, you know what, it'd probably be best for folks, because I'm not going through this in extreme painful detail, to go on to keep going there till it should be slide like 12. Yeah, here we go. So just because a lot of people want to hear brass tacks, you know, what are the valuation of these codes? And what's a brief summary of the descriptor? But the key codes.
Well, one of the things that we want to make sure, and my understanding was that the 99091 and the RPM codes, which are up on the screen now, are in a different section of the code book, and that the RPM codes are not physician focused, and that our ancillary service providers are allowed to use these codes. That was one of the things, and that was where we really needed to get today, was not just, you know, how much do the codes pay, but who can use these, and what are you hearing? You know, we're hearing different things from the American Medical Association as far as CMS allowing, you know, our sort of non-traditional telemedicine, telehealth, remote patient monitoring providers, such as PTs, OTs, and SLPs, which is really what we're talking about today, and being able to use these codes. Is that, you know, this is really what we need to find out. Is that something you can speak to?
Yeah, in part. I wish I could give you absolute clarity. I think ultimately that has to come from CMS probably, and I hate to give that caveat, but you know, it is what it is. You know, I think because we don't have that guidance from CMS I was mentioning earlier, the experiences I have that I can share at least are things that have kind of filtered up through our association. Experiences that people have had submitting claims to different MACs and stuff like that. So in some cases, I've seen PTs have remote patient monitoring CPT code claims blanket rejected because they were told that physical therapists aren't able to bill evaluation and management codes. And in other cases, I have heard of claims successfully being filled, and I have seen some data showing physical therapy, for example, as a category of claims that have been successfully filled for the 99453, 4, 7, and 8 codes in the last year. So I may have added to the confusion there.
Well, what we've heard directly from the AMA last week was that the RPM codes that are here can be charged by ancillary services, but they can't be charged on the same day that other E&M codes are being charged, or they will. They can't be on the same day. So if you're going to drop RPM service codes, and this is something that that the AMA is going to be on another day to confirm, is that the E&M codes, which these are under, can be dropped by ancillary service providers, PTs, OTs, and SLPs. They can't be dropped on the same day that other E&M codes are being built. So you would have to get your timing so that you're doing it on a day that you're not already dropping E&M codes.
Right. That's I mean, you know, I have a lot of deference to the AMA's perspective on that, but ultimately, I think, you know, there's some clarity. To me, I would still love to get that absolute clarity from CMS, because I was quite confused when I did hear. I heard about you know, a particular provider who was having their claims, again, it was like blanket rejection, and that was the reason. The reason they were getting was they said PTs are just totally ineligible to bill these codes, and I was confused by that. Sometimes when it's egregiously bad with a MAC, we'll even motivate CMS to go in and correct things, which is something we're trying to do there.
Okay, maybe you can speak a little bit to these codes and just help people, walk people through, what's initial setup, what's the scenario that you're in, and are these with video? Is this without video? What are some of the parameters around these remote patient monitoring codes that you have up on the screen?
Yeah, absolutely. So yeah, this is kind of these codes, and you could almost for purposes of what I'm about to say, you could leave out the 99091 code, but or maybe not. I don't know. Sorry, I don't mean to be confusing there. But the way that they're listed here from top to bottom is intended, I think like CMS is to kind of trace through chronologically the way that RPM would be used. The 453 code for initial setup and education is a one-time code. You can only charge that once. The 454 code is device supply, which is kind of a interesting term. It means different things to different people. But my take on that is what the 454 code you can bill every month, and that is contemplating an equipment rental situation between the provider and the supplier of the device. And then the 457 code is for the actual time, manager evaluating that data. And then the most recent addition is the 458 code, which is if you needed to do review more than 20 minutes for that patient in the same month. The biggest barrier, and one that we have attained clarity on, was that due to the wording initially when they activated and paid for these 4 remote patient monitoring, or 3 originally remote patient monitoring codes, the wording that the CMS used translated to that that either the physician themselves or the clinician themselves had to undertake the review, or clinical staff could undertake the review under their direct supervision, not general supervision. So in other words, that required the clinical staff to be in the same facility physically.
Right, but that's since been changed, right, Brian?
It has, and CMS did not intend to place that constraint on these new codes. So they have clarified that general supervision is permitted, which is that's one less thing to deal with. That, but we kept hearing out there like that was the loudest complaint.
Right. So with these codes, these codes right here are not telemedicine codes. I just want to make sure that we're clear. So these are codes that our users our listeners can use when they're receiving data back from their patients that they're taking a look at, and the patient is either not in front of them, or when they come back in, they're going over it together. Have you heard anything? And what people are asking is, have you heard anything about, did it need to be relaxed? Did COVID make changes to this? Or, I don't think that laws around this remote patient monitoring services needed to be relaxed, because these clinicians were already allowed to bill these services ever since for in the fee schedule were around the direct supervision. So these are codes that PTs, OTs, and SLPs can charge now. Is that right?
Yeah. I mean, as long as, and again, I defer to that guidance you mentioned that the AMA gave you there. Again, I'd love to give you a written statement from CMS, but assuming that you're right there, yeah. I mean, some other barriers though for people to think about with these codes is this is your review of data that's collected and transmitted to you at some recurrence. The transmission from the patient to you has to happen 16 out of the 30 days in the month. You need to spend an aggregate with the new codes of 20 minutes per patient per month. And so another barrier or question I think that has come up, and we've heard this has again floated up through people having claims rejected or accepted, has been what these are when we say RPM for these codes, it's remote physiologic monitoring, not patient. So the term physiologic, no, it's not defined by CMS as far as I know. I have heard of claims being rejected because the data was not physiologic, quote unquote, right? Again, in the PT context. So there's some examples that CMS has given, pulse ox, for example, but
okay, Brian, we're coming close on time. I want to learn through everything on remote patient monitoring. Can we talk a little bit about the telemedicine? So a lot of places are trying to implement video visits. They're having to close out patient services, and they're trying to manage their patients remotely through the use of video. Can you talk to what can they do? What are the changes? What's been relaxed? What can they do? How can they repurpose people to do video visits to take care of their patients?
I'm sorry, just to be clear about with these latest changes, right? With the latest allowances made. Yeah. So there's been a number of allowances made by the agency with respect to digital health. I think they've granted, as part of a waiver, they have expanded the availability of telehealth services. They have, for example, removed requirements on the geographic requirements. Usually telehealth is restricted to a healthcare professional shortage area, which effectively excludes any suburban or urban area, for example. And they're not basically enforcing that now. They're not conducting audits about that. There's also the virtual check-in codes, which are quick, under 5-minute phone calls that can be done, and those are paid for. They've clarified that they foresee those being utilized here.
And do you have those codes in this slide deck?
Yes, they are.
And can those be used by PTs, OTs, and speech therapists?
I am not 100% on that. I wish I could tell you absolutely yes.
The changes that they've made?
They are paid for. Yeah, they're all paid for. Yeah.
Okay. And with the telemedicine, I know eligible providers used to be a requirement. Is that one of the things that they've changed?
No, I don't believe that they have changed that. No. That's,
okay.
I mean, that's an issue that we're continuing to ask for allowances by Congress. I mean, I think basically what the agency will tell you is probably what they've told us, which is that despite this being an emergency, there are still some things that they cannot do without Congress acting. So, expanding the list of eligible practitioners,
Okay.
yeah, it's definitely, to me, it's a congressional ask. I'd love somebody to tell me I'm wrong and show me the authorization that they have, unfortunately.
Is that something that your group is currently lobbying for?
We are.
Okay. What's the slide deck? Where do I need to go for the video visits? And or not the quick visits that you had mentioned that we can see those codes? And does that have an eligible provider requirement or no?
My understanding is they do. Yeah.
Okay. So really at this point, even with the things that have been relaxed, the only reimbursement that this target audience is going to be able to apply for are going to be with the remote patient monitoring codes.
Yeah, and here's another nit for you, and this is something I wanted to make sure to emphasize is we're in the midst right now, and I'm very hopeful we're going to get this clarity from the agency rather than Congress in days. But as it sits right now, the RPM codes can only be billed when a patient has one or more chronic conditions. COVID-19, as I learned recently, is an acute illness, not a chronic condition. So there's great uncertainty, unfortunately, right now about these RPM codes even being able.
That clarification in the link to the chronic care management was not intentional, according to the AMA, and that's
right.
with the same guidance that's coming out where around the E&M codes.
Exactly.
Where they don't have to be tied to chronic. You don't have to have multiple because that, you know, no, that.
I share that view. I share that view, but unfortunately, there's because of an error basically in taking a header and calling the codes chronic. I mean, there's unfortunately there's some very plain text in the regulation which constrains the use of the codes to remote patient monitoring. So something more is needed from the agency to enable RPM codes use for this. And we worked quite closely with the AMA on this topic for some years, and we were extremely excited to see them express the view that you just said to the agency. So we're quite hopeful that we'll get some clarity there. I believe that the clarity we would need as far as RPM codes use and COVID-19 and other acute illnesses should not even require a rulemaking. They should just provide some sub rulemaking clarification so we can just go and do it.
Yeah, I mean, yes, but we have to know what we can act under. And so that's something that we're trying to get from the AMA this week is, you know, an official statement around the fact that it doesn't require chronic care management, and you don't have to have multiple diseases that you're trying to manage on a patient before you can use RPM codes.
Right. Yeah.
Okay.
I mean, you know, for some, I mean, even without the change, I'm just trying to think practically. I can see a good number of I mean, especially with people with existing chronic conditions being more vulnerable to COVID-19, that I could see this maybe not being a bureaucratic constraint that their provider would face. But for others, definitely, I mean, we are hearing that people like are, you know, their legal department's throwing a fit and they won't do it. So it's just, like, come on, CMS.
Sure. We just need to have, you know, things that we can act on.
Yeah.
Okay. Well,
yeah.
I know you go into that. Some of this is going into MIPS, which I don't know that we need to cover today. Is there anything else that we can, that's ancillary focused, that we can give our viewers and listeners as far as, you know, who are considering starting to do some type of remote management with their patients? Is there anything else we can give them today? Anything that
you know, just to touch on a few things, if you go to maybe if you go to slide, and by the way, rather than go through any of these QPP slides, the other day CMS paused all reporting requirements for QPP, as I understand it, for the duration of the COVID-19 emergency, which is probably not to speak for the physician, you know, community, but I'm sure it sure is a welcome step. If you go to slide like 21, maybe you should see like a map there. Yes, okay. So this isn't necessarily something that you might think would come up here, but I just did want to briefly mention that as far as, you know, infrastructure and connectivity, there already is, and there's going to be some further steps that may, you know, that may that you may be able to be direct beneficiaries of if you're looking to offer these, you know, new telehealth or remote services. Namely, the Federal Communications Commission is in the process right now of finalizing a connected care pilot program where they're going to pick a healthcare providers, basically, long story short, healthcare providers put in a proposal because they want to stand up a connected care system in amongst their population that they're serving, and then they're given an allocation, and then they hold competitive bids with partners, including telecom service providers, including technology partners, et cetera. And the program is, and so that program is being finalized right now. There's also something in the mix on the Hill right now that would give even more money to the commission to enact a pilot program. So just something to think about there, especially if connectivity is an issue.
So that's great. So we've got a few minutes left, and then I really want to get to some of these questions. So anything about the that you can talk to about some of the HIPAA things that were relaxed around HIPAA, and technologies that can be used?
Yeah, absolutely. That's a key clarification, I would argue, has been that, you know, the Office of Civil Rights, who's like the enforcement arm here for HIPAA, has pretty plainly announced that they're going to exercise enforcement discretion and waive penalties for HIPAA violations against providers that serve patients in good faith during the COVID-19 emergency. And they specifically call out some widely used communications platforms that could be used. They include like FaceTime and Skype and things like that. So, I mean, I've heard, I'm curious too, if people don't think that's enough or whether that's not important to them, but I've heard from a number of different stakeholders that that's been a pretty, you know, of all the different things that HHS has done, that's been a pretty key clarification there. Also, the FDA has more or less issued some emergency guidance. Again, this is only in effect for the extent of the COVID-19 emergency, but it's addressing non-invasive remote patient monitoring medical devices, and you know, as I understand it, it's essentially stepping back in its approach that it had taken to clinical decision support software to enable more CDS to get on the market. And so again, I've heard that that's one that some folks have been you know, been praising, been thinking about. I'm curious if others. I mean, this did just happen like 2 days ago, so I'm curious what other people think. And we've been also having some informal discussions with FDA about what they could further do to streamline a pathway for, you know, some kind of narrow AI use that would address specific COVID use cases.
Right. Okay. So
yeah.
I think at this point, Brian, we're gonna take a look at some of the questions, unless there's anything else that is specific to, you know, how are we gonna get these clinicians up and running on telemedicine, and, you know, and virtual visits and those types of things. I understand, I mean, I'm with you on the FDA things, and I think those are probably a little bit more outside of the scope of where we're focused on today. So if we can go ahead, I mean, unless there's anything else in the presentation that we need to cover.
Maybe just briefly, this slide you're on right now, and there's a document that I sent in to you, John, beforehand. If it's helpful to distribute it, this includes some. Oh, these. I'm sorry. I was thinking this was the next slide. Could you go to the next slide? That's what I was thinking about. Yeah, there we go. So some further things that we are hearing from the stakeholder community need to be addressed and have not been addressed. You see some of them listed here: copays, AKS. You know, we talked about the scope of who can bill and things like that. At least getting clarity there. Interstate licensure, et cetera.
Okay, so those are things that are in process.
Yeah, in process, under consideration right now on the Hill. So, and you know, and if it's worth, just to be as topical and timely as possible before I stop blathering to you all, you know, right now there's the attempt is to get alignment between on this massive appropriations bill that originated in the Senate, got, you know, and then the House worked on its own thing, and now there's 2 different versions. They've got to align before this thing passes, and you've probably seen some headlines about how deals have fallen through so far. One pretty timely angle, one key angle that a lot of people are focusing on because it's realistic, I think, is the Senate bill's blanket waiver of 1834M versus the House bills, which omits such a provision. So people are really trying to convince the House to wake up and align with the Senate bill on that. But, you know, there's a partisan angle. There's all kinds of other.
What would that mean for what would that mean for our listeners?
So that would mean to the extent that anybody is involved in a Medicare telehealth service billing operation, that they'd be able to offer such services to people anywhere in the country, not just in HIPSAs and in their home.
Got it. Okay. Okay. So I want to get to, thanks, Brian. I want to make sure that we cover any of the questions that are coming out. So the first one is, can the RPM codes 99457, 58 stand alone, or do you need to use 453 every time you enter these codes?
No, I believe I think, if I understand you right, I think they can stand alone. You don't need to, so 453, you can only bill one time at the initial setup. You know, I know of no requirement that the device supply has to be billed alongside the code for your time spent reviewing the data. They're not bundled.
Right. So this is a service fee. So if you don't get the 20 minutes on a patient or an additional 20 minutes, this is still a service that can be charged. And then if you're in month 1, you do the initial setup, you provide the service, you can get 5.3 and 5.4. And then if you don't get 5.7 or 5.8 because, you know, for whatever reason, if you don't spend 20 minutes, if you don't hit your 20 minutes with that patient that month, then you would be able to drop 5.3 and 5.4 and just not 5.7 and 5.8. Is that right?
I guess that is possible. Yeah, if you don't hit the threshold for the professional component of the RPM service, you can bill for the 2 technical components. In the first month, you can bill 5.3. On an ongoing basis, you can bill 5.4. The difference and not to confuse people, I apologize if I have, but the difference between the 99091 code, which is again the 99091 code, and the 5.7 and 5.8 code, is that the 99091 code is restricted to the physician itself. So if you're not a physician, you basically can't bill 99091. With 457,
the 9.1 is the physician code. 5.7 and 5.8 are not.
Are broader, yes.
Right. And these are 5.3 and 5.4 are PE codes, and 5.7 and 5.8 are RVU.
Yeah.
Yeah. So the next question was, is this only for Medicare? Is there any information regarding pediatric outpatient population? So anything from Medicaid that you can speak to? Or
yeah,
this,
let's see
everything
here.
that I've seen for Medicaid is just running on a state-by-state basis, and that some states have that and others they don't.
Yes.
Is that?
Yeah, it's true. Yeah, it's a total patchwork when it comes to states supporting telehealth versus remote patient monitoring. Some states don't even use the phrase remote patient monitoring in their law. They'll say store and forward, for example. Some states have parity, others don't. Wide variation there, unfortunately.
Okay. The next one is
a resource. I should actually, to give full credit to it, it's not our resource, but it's called the the CCHP, Connected Care Health. I apologize for not knowing what the acronym stands for, but it's a California-based nonprofit that tracks state developments with respect to digital health widely, including like live voice video and, you know, RPM or store and forward, et cetera.
Mm-hmm. There's one of the guests that we're having on is from the Southeastern Telehealth. It's a federal, there's 12 of those banks around the country where they gather that information. She's going to be coming on next week. And we'll post a link out. It does have a breakdown of state by state, what laws have been passed. So you can, and we'll put that out on the ACRM website, where you can do a search for your state and it'll tell you exactly what laws have been passed for Medicaid, as far as remote patient monitoring goes, and what you're allowed to bill in your state.
Yeah.
So let's see. So the next one was, So right now, PTOT and speech therapists cannot bill Medicare Part A for telehealth. Is that correct?
So Part B is what I know about. And what I was saying earlier was that at least one MAC holds that view.
Okay.
They did. I don't know if they're right. I hope they're not right. I disagree if they think they are. And we're trying to get the agency to provide clarity for all MACs so that we don't have to deal with that anymore.
Okay. And then we did talk about the virtual check-in, where at this point that's an eligible provider only.
Yeah,
Is that right?
I believe so. Yeah. Yep.
Okay, and then e-visits. We didn't touch on what's the difference between a virtual check-in and an e-visit? And can you talk about e-visits? Who can participate?
So I believe as far as the scope of who can bill, it's the same as for virtual check-ins. Like a virtual check-in. So a virtual check-in, here's the difference: is a virtual check-in are there's some of the ins and outs with virtual check-ins versus e-visits. You've got to have an established relationship with the patient for a virtual visit. It's not limited to rural settings or certain locations. It's supposed to be technology agnostic, but the use case that they provide is anything with an audio visual capability for real-time communication. And it's like a 5-minute check-in that is not associated with a visit that you had in the last 7 days.
Right, so
yeah.
PTs, OTs, and speech therapists were cleared to use the G2061 and 63 codes.
Oh, for e-visit. Yeah.
There were questions around what it actually pays, or if it has a dollar amount attached to it. Do you know if that, can you speak to that, or do you know what the dollar amount is?
I guess I'd love to follow up with you on that one. I mean, okay. I know even for some of the latest guidance, it's not spoken to.
So that was from Carrie. Carrie, we'll post out on the site. I'd seen that before as well, that PTOT and SLP were cleared for those codes, but what I had found was that we couldn't find a dollar amount attached to those. So we'll see if we can get an answer either from AMA or CMS and post that out on the site. So I'm sorry I don't have more clear information we don't have more clear information for you on those specifically. I want to go to the next one, home health. Brian, can you talk about as far as home health goes, even though the Department of Health has decreased the visit we can do in home to only for critical, it seems we should be able to bill for all the other patients we need to still keep tabs on. Any guidance around home health and what they're allowed to do?
Oh, I should say, actually, sorry about this, but somebody in your chat just hopefully provided a link. I don't know what the website is exactly, but they pulled out the valuation for these codes for the.
Okay, great. We'll post those out.
Yeah. Thank you for that.
We'll be posting a copy of the PowerPoint slides and everything else on the ACRM site that we have for this. So those will be available. There was another question around there was a few questions around private insurance. So the feedback that we've gotten around privates is that and this again, I hope the AMA knew that they were on the record during this phone call, and we'll continue to take our calls after this presentation. But that so they're meeting with the private insurers daily, and that for the first time, it seems like, usually the privates do what they want, and then the AMA is trying to catch up. And actually the opposite is happening. They're having calls with privates every day. Privates are looking to the AMA for guidance, and what they have been told is that they're pretty much reimbursing for everything. So the CMS, as usual, and I don't mean to bag on them, but they're sort of late to the party. And we're waiting for them to come around, but the feedback that we got here from the AMA was that the private insurers they're pretty much paying for whatever. They're doing the RPM codes. I haven't gotten that on. I do have a caveat on telemedicine. I don't know that they are paying for telemedicine across the board. So for those, I would reach out to your private payers that make up the bulk of your payer mix, and ask them about the telehealth to see. We didn't have an answer. So Rachel, we didn't have an answer about home health. The home health agencies unfortunately do vary a lot state by state as well. Have official guidance around home health for the remote patient monitoring code. So
There's some I can offer. Yeah, I can offer something. I know. I hope that it's slightly helpful at least. Is what we do have is we do have a confirmation from CMS that under the home health perspective payment system, that the costs for remote patient monitoring are eligible administrative expenses that can be billed as part of the prospective cost monthly. I know that doesn't necessarily, I've heard from a lot of people that doesn't necessarily solve all of the problems or answer all of the questions, but CMS has provided that clarity at least.
Okay, and can you post that out, Brian, or do you have a document that we can use for that we can post out after?
Sure. Yeah, it's I think it's like quoted without attribution to CMS. That is okay. One of the slides here too.
Someone had asked a question about 458 and 57 about was there a specific number of visits? There's not. I know that they're the only two requirements that you have to have for RPM charging is you have to have one face-to-face visit, and you have to get a consent from your patient. So one face-to-face per year. So yes, I guess there are visit requirements, but you only have to do one face-to-face per year and get a requirement in order to bill RPM, the 53, 54, 57, and 58 codes.
Yeah.
Okay. Fee schedules, great. Links, thanks, Alan. E-visits, clear distinction between e-visit, briefly e-visits and telemedicine. What's the definition that's differentiating those two?
Let's see here. I guess the e-visit, it may be I know that like the services are being initiated by the patient. So I guess I would put it this way is I think that the e-visits are intended to incorporate so it's about the use case is what really comes to my mind. For virtual check-ins, they're essentially talking about a quick phone call, like a voice phone. Really, they are. It's like a quick phone call to the provider or sending them an image to evaluate. So for the image, you can think of probably the dermatology use case or something. With e-visits, those are intended to be, as I understand it, covering communications over EHR platforms between patients and providers.
Right, got it. So versus telehealth, which is a video visit.
Right.
Someone had a question about they have a virtual reality rehab technology they're using to monitor patients at home, and wanted to know if this is something that can be billed. Device can be rented out under 454, and then using 457 and 58 as a treatment and management. Are they correct in that their understanding of them, of the codes?
I believe so. Again, this kind of gets back to one of the nits that we're still working on, which is the scope of what physiologic data is. If you're a super conservative claims, assessor with a MAC, and you decide that only, pulse ox and a few other, like classic physiologic readings count as physiologic data, then they might deny the claim. I mean, that's something that I think we just need uniformity and clarity on. So I wish I had a yes, no for you there.
Okay.
Yeah.
At this point, I'm going to go ahead and wrap things up. We've got a couple of housekeeping things before we finish the call. Brian, thank you for being available today. I know that your group is, again, trying to pay attention and influence what's going on in the Hill. If there's any guidance that you can, if any of our listeners and viewers have influence with politicians that are making decisions around this, what would be the one thing that they could focus on? If they
I would, yeah, I would first, I would just ultimately, I would just make your presence known and make your voice known like yesterday. I mean, now it really is that critical of a time, and it really does matter. I think where we're looking at making the most realistic progress is in addressing basically a removal of 1834M restrictions for telehealth. Realize that doesn't affect everybody. It certainly doesn't affect the entire constituency that that I'm representing, but it's a key incremental step. And something else to think about too, and I've heard senior HHS people tell me this, is that the changes that we make now for purposes of the COVID emergency that prove effective and helpful, I think that in practice, the government will have a very difficult time walking them back once the crisis is over. So
we'll post links. Yeah, we'll get some links from you, Brian, where people, and I encourage everybody that's on the call today, these are the types of, your voices are influential. And we'll post links where you can go, and we'll get the messages to Congress so that they can understand and hear directly from the people on the front lines of why these are so important in the services you're trying to provide or that you're trying to provide your patients, and keep the wheels on the bus. We will be on Thursday with Carrie Nixon, the head of the Nixon Law Group, specializes in billing consulting. So she's very in tune with what's happening with the charging as well. And then we're going to be doing representatives from ASHA, AOTA, APTA, and the White House the following week. So thanks everyone for joining us today, and I hope we'll see you on Thursday.